Today we have with us Michelle Demarest. She is a licensed speech language pathologist in New Jersey who is board certified by the American Speech Language Hearing Association and holds her certificate of clinical competence. She also is a certified brain injury specialist and provides cognitive remediation therapy in a variety of settings. She is trained at the second level in the use of prompts for restructuring oral muscular motor targets, talk tools, oral motor placement therapy, and orofacial myology. She has expertise in the treatment of myofunctional disorders, cognitive remediation, articulation disorders, aphasia, autism, apraxia of speech, voice disorder, and dysphagia. Thank you so much for being here with us today, Michelle.
Thanks for having me. It's great to be back. This time I was here talking about speech and LSVT, so I'm glad to be back. All right. My name is Michelle Demarest, and I'm going to talk today about Parkinson's and swallowing. I've been practicing for quite a while, and we use both in-person and online therapy to treat Parkinson's patients here in New Jersey. And I have no financial interest to disclose. So not everybody knows, but did you know that speech therapists treat speech, language, cognition, swallowing, and also work with audiologists? I bring it all up because you may have the opportunity to work with a speech pathologist, and you should know that how useful we are in a variety of with a variety of issues you might experience as someone with Parkinson's. So today we're going to talk about swallowing. Swallowing changes in Parkinson's disease. And some of the changes you might see are chewing for longer than usual, having food or drink fall out of the mouth, difficulty using your tongue to move food around, difficulty initiating a swallow, just like difficulty initiating other things as well. Feeling like food or liquid is stuck in your throat, coughing and choking, drooling, difficulty physically feeling what you're inside your mouth, what you're eating. And you may experience, weight loss or dehydration or malnutrition. So, I'm sorry. The reason we are presenting this is because if the disease has progressed and you're not getting treated for having difficulty swallowing, then you may end up with aspiration pneumonia. And this is a type of pneumonia that is caused by something other than air being inhaled into your lungs. And this could include saliva, food, liquid, vomit, or even other objects. It causes inflammation in the lungs air sacs, and then that gets infected. So some of the symptoms include chest pain and the rest of the stuff listed here. You should be aware of it because you don't want to get it, and you often end up in the hospital if this happens. But the treatment depends on the severity, and it is treated with antibiotics. There are other types of pneumonia as well, but it's something to be aware of now, so that you take care of getting any you can get for pneumonia, which would be a viral pneumonia, and also to start just paying attention to your swallow and taking precautions to make sure that it doesn't happen. So aspiration is when the food or liquid goes into the lungs. And there are certain factors that might increase the propensity for you to have aspiration when you're dependent on others who may be feeding you, dependent on others for oral care and oral health, less mobility, a weak or reduced cough or reduced respiratory health, multiple medical conditions, and overall frailty, and the type and amount of things that you might aspirate. And we'll talk more about that later. There are worse things to sort of get into your lungs and better things. And so you can see the three pillars that might lead to aspiration, pneumonia. See, sorry. Good. So what does a speech language pathologist do in this case? An SLP will evaluate your swallowing by providing you with various consistencies of liquids and solids. And if there were concerns that SLP sees, they may suggest that you get a more technical test. That test is called a modified barium swallow study, or also a video endoscopic swallow study. So when we would work with your doctor to order that, and then that test is done under X-ray in the hospital. This is the video fluoroscopic swallow study, or the modified barium swallow study. This is the test that we're talking about that we would do if the speech pathologist feels that it's necessary. Often it becomes necessary as the coordination and flexibility of the muscles for chewing and swallowing become more rigid. So this is a test that's completed in a room with special X-ray equipment, a speech pathologist, and also a radiologist. It's recorded via video. You drink and eat food that's coated in barium, so it will show up on the X-ray. The SLP, the clinician, observes your swallow, and then they try to do different strategies with you to help you improve your swallow. So let's take a look at this if we can. Here is an example of here's a video of someone swallowing.
If you could imagine your ideal way of working,
hold on.
What would it look like? Monday.com can make it your reality.
All right. So in a normal swallow, food goes down into your stomach. And that was an example of food going down into your stomach. In a swallow that we're talking about, it would go into your trachea. Your trachea is the tube that leads to your lungs. So let's take a look at that. She triggers the swallow, and some of it went down toward the stomach, but a lot of it went in the tube in front, and that is going to lead to the lungs. So let's just take a look at it again. It's interesting to see. The person's going to eat, and it went straight down into the stomach, right? And here's where it goes partially into the stomach and partially into the lungs. And if you will take a look, do you see how there's a pool of liquid here? That's at the base of the tongue. And at the beginning of this swallow study, let's see, let's do this one again. It really pools there. And this little flap here is called the epiglottis. And let me stop it. And the epiglottis is having trouble folding down to allow the liquid to go down the esophagus. When it finally does, it does it only partially, and that's why some of the liquid goes into the lungs. Another kind of test is called the Fees test. And this is when they thread a little black camera down your nose, and they watch in real time, watch you swallow from above. and they would feed you different consistencies of food and liquid, just like they did in the modified barium swallow. And then they can, it's interesting because you can see it in real life while you're sitting there. You can watch yourself swallow, and you can always ask whoever's there to show you. I'm not going to show you that right now because I'm scared it's going to happen again. All right, so after a swallow study is conducted, your evaluating therapist is going to write a report. So will the radiologist. If you had the modified barium swallow study or the VFSS, the evaluating therapist at the point when you're in the hospital, after they've done the swallow study, they should talk to you and answer all your questions and tell you what has happened, what's going on. It's their duty to do that. Sometimes we get busy, and I can imagine if they say, oh, do you need me to talk to you? Say, no, I don't need you to. You do need them to talk to you. Get them to talk to you. And then please get their report. It's so important. Once they've looked at the results, they're going to suggest exercises to help you improve your swallow function, strategies for you to use to improve your swallow function, and a diet modification if needed. And so the exercises to improve swallow function are would be given to you. And so what I thought we could do today is to try some of these. So the first one is called the shaker exercise. And if anybody's lying down or can lie down right now, you can lie down and you're just going to lift your head off the pillow and put it back on. Lift the head off the pillow, swallow, and put it back down. So I can't demonstrate that for you right now, but that's an important exercise that will help you to train the muscles under here to make sure that when you swallow, this part of your anatomy goes up as high as it needs to trigger that epiglottis to fold down. Anybody trying it? All right, another one's called, well, there's the Mendelssohn maneuver, there's chin tuck against resistance. And that you may have heard of. What you're going to do is tuck your chin. And at that point, you take a swallow and you swallow. And sometimes this will help make sure that your epiglottis is folded down and going over your trachea so that you don't aspirate the liquid. So that's one that is often suggested. For people with Parkinson's, often using a straw is indicated because your tongue's not moving fluidly. So when you put it in your mouth, it goes toward the back and you stop and swallow, and there's less chance of aspiration. I don't know how many people are having any symptoms, but if you are feeling like you're having symptoms, like we talked about before, it's important to get in touch with a speech pathologist, and you can be seen in person. You could even be seen online if necessary to get a swallow study, a bedside swallow study done. So that's what somebody like me who's not in a hospital would do. Another interesting exercise to improve swallow function is pitch glide. People don't realize that, but just by making your voice go up and down in like a siren, you're actually training the muscles that are above this little bone here. And so we can all try that together. Do your siren. Ooh. That's a siren. I don't know if we can unmute everybody, but it would be great to hear everybody try to do a siren. All right. An effortful swallow is another way to do it. You push down on like the chair you're sitting in, like this, and you swallow, and it's very effortful when you do that. And that helps trigger things and gets that epiglottis to fold. And then there's something called expiratory muscle strength training, which is a newer thing they've come up with. And I think I may have shown it at the last webinar. It's basically a tool that you breathe in and you breathe out, and you can increase, you start at a low level and then you increase it to a higher level, and it's training your lungs, making sure your lungs are strong enough to expel that fluid if it were to go down into your lungs. Here's some questions. Who needs to see the reports that you might have be generated from the hospital? You and your caregivers need to see those reports for sure. You might be able to get the hospital to give them to you before you leave the hospital. And also you might get a thumb drive that would give us a video. The therapist would love to see that. It'll really change your care. If the treating therapist, someone on the outside, can see what was going on during that test. All right, so that's that. Sorry, this is out of order, but here's some other swallowing strategies. These are not exercises, but strategies. So the swallowing strategies often are taking a bite, then a sip. If you're noticing that food gets caught in your mouth and you feel like it's getting caught in your throat. You can do the chin tuck like we talked about. We can do a double swallow, which means swallow, pause, and swallow again. You can do something called the supraglottic swallow, which is you hold your breath, swallow, cough, swallow again, and now breathe. And then you could do that whole routine again while pushing down on a chair. Yeah, so do you guys, I don't know if it's everybody seated and you guys could try it. Why don't we try it? You take a deep breath in, swallow, cough, and swallow again, and now breathe. Very good. All right. Any questions or comments at this point that I need to address?
My own questions. One, what does the pushing down do? And then also for the chin tuck, because I tried it, do you need a straw for that? Because I thought, like, how do you tuck and then drink?
You have Parkinson's, you very well may need a straw.
Okay.
For that, but you might not. You're using intraoral suction to get it back. You're pushing your tongue up to the roof of your mouth.
Mm-hmm.
And that's how we all swallow. We lift our tongue to the roof of our mouth. And with Parkinson's, that's why it's so important to continually do the therapy, because we can make sure that that tongue's still getting to the roof of the mouth. As soon as that stops happening, we're at a deficit. So that's for the chin tuck.
Mm-hmm.
And then your other question?
Push down.
Oh, when you push down, you're helping your vocal folds smash together. You're holding your breath. It's helping you really hold your breath. And you can feel it, right? Right about here. Yep. And so when you're holding your breath, your vocal folds are together and they're creating a barrier so the liquid can't get past them. Mm-hmm. Or the food can't get past them and go into the lungs, because the vocal folds are just on top of the lungs in the trachea. Does that make sense?
Yes. Then one other question. Yeah. Does it matter if you have saliva saved up while doing these exercises?
Yeah, it does. And so it depends which one we're doing. These are the strategies, and then the exercises are the other ones. Yeah, because you can aspirate, anything can go into that epiglottis, right? The front tube, the trachea. Sorry, anything can get into the trachea if things aren't working right. And so saliva can also. Now, saliva, well, we'll get to it next, but saliva and water are now that they've done the research, they found that they're less likely to cause pneumonia. So let's get through the modifications, and then I'll tell you about the free water technique. All right, here are the diet modifications. This is the international dysphagia diet. Dysphagia is not being able to swallow right or chew right. And there are different levels of food and different levels of drink. And so the 7 food levels are regular, soft and bite-sized, minced and moist, pureed, and sorry, I gotta move my, can you guys see everything on my screen, including the people? Okay, liquidized. So those are, and then we haven't listed the other ones, but those are the ones that most people would use. And then for drink levels, thin, slightly thickened, mildly thickened, moderately thickened, and extremely thickened. Most therapists will use this, though, and they'll use the international classification, but this is how you'll hear them talk about it. So when we have a liquid, in order to slow its progression down the tract, we might thicken it. And that way it's heavier, and that gives your body time to react. And so thickening helps reduce aspiration risk. You would add cornstarch or some different gums to it. It's available as a thickening agent. You can go to CVS or online. But if you've ever made gravy for your Thanksgiving turkey, you know that you can use cornstarch to thicken that gravy. Same idea. So the regular liquids are thin liquids like this, right? This is not changed at all. And then we can put a little bit of thickening in, and it makes it nectar thick, sort of like a nectar. Next is honey thick, moderately thick, which is pretty thick. And the last is pudding thick. And this is literally as thick as pudding, and it will not allow you to meet your hydration needs. So that's a pretty severe case. Diet modifications, the way we usually talk about it is whether we've chopped or pulverized it. And when we don't have to chew it as much, when there's less effort in chewing it, you would reduce the risk of aspiration. So you could use a knife, a blender, and also you might add thickening agents to this as well, especially if it's like a puree. So we have regular, no changes or adaptations. Chopped, meat would be chopped up. Soft meat is ground up or pureed. Food is blended into the consistency of applesauce. And so depending on the level of slowness with which your body reacts to swallowing that food, or chewing it, and the level of disorganization, a speech therapist is going to recommend this diet level. You might see it if you are ever hospitalized, but you may also be sent home with it, asked to, you're on a chopped diet. In other words, you're not going to just eat a piece of steak. It's got to be previously cut so that it's safe for you to eat. It's a hard thing to manage in a hospital setting, and of course, people don't like it. But that is part of the job of a speech pathologist, is to get people to see if they can, do these things so that they don't end up, getting aspiration pneumonia or continuing to have it. There's also adaptive feeding equipment. If you see here, you can see a plate guard so that if it's hard to maneuver your fork or spoon, you can push it against the side of the plate. You can use these at home as well. There's lots of different cups and straws out there now that would help you. And we can, if people are interested, we can go through some of those at another time. There's something called Dyson, which is this little blue sticky pad like thing that helps stick your plate to the table or your cup. And then also reminder cards: swallow with purpose, swallow hard, and check your posture. Often with Parkinson's in the later stages, we're going to be forward. And when we're forward like that, that food's going to fall out. And it's very hard to swallow when you're forward like that. You shouldn't try. So those reminder cards remind us to sit up straight, etc. And does anybody have questions on this one? Nope. Okay. All right. Now, this is very interesting and it's relatively new research. So there's something called the free water protocol. As we get, if you needed to have a modified diet or modified liquids diet, you would feel thirsty. And so that's doesn't bode well for quality of life. But sometimes you can chew on ice cubes, or it sort of depends what your level is. So the free water protocol, or the Fraser free water protocol, is designed for patients to drink water outside of their meal times, even if they require a thickened liquid during meal times. And it's only recommended for people who have enough cognitive function to follow the rules. One is maintaining oral hygiene 2 times daily prior to drinking the water. Drinking the water at least 30 minutes after eating, and not drinking water during meals. And the way this happens, why this works, is that water is a neutral substance that's less likely to cause complications when aspirated. So it's less likely to trigger a pneumonia, just like your saliva. But it's controversial in certain patient groups. This protocol did not contribute to lung infection rate, and then others it did. So I think people, there's more research to be done on it. A lot of people think it needs professional monitoring constantly. One of the things I didn't mention is you can aspirate without knowing you're aspirating, right? Usually if we're choking, we're coughing, right? But that doesn't always occur when you've lost some of the function. You're not gonna cough. You're not gonna be aware that something's hitting your vocal folds. And so if you have what's called silent aspiration, it would be very hard to know if you're aspirating. And that's another reason why we send people to get a modified barium swallow study. Lastly, LSVT and Speak Out were 2 programs that we discussed during the speech portion, speech webinar. And these ones are shown through research to have an overall reduction, if done, an overall reduction of 51% reduction in the numbers of swallow motility disorders. And motility means movement. So that's huge. And it's another great reason to, engage in therapy early and often. So that's pretty much it. That is the slideshow. I tried to keep it very short this time because I know we went over an hour last time. Hope I wasn't too short.
And also, did you want to share the videos?
Oh yeah, that's a great
idea.
idea.
Yeah.
All right, so I'll go up here. So this is another, so up here we had talked about the video, the MBSS or the VFSS, and we saw that video. The next one is when they're threading a camera down your nose into the top of your throat. And let's take a look. All right, so this is a short video and it's showing somebody swallowing applesauce. The applesauce has been dyed green. And you can see that the applesauce doesn't go down very well. It's stays up near the epiglottis. So here, let me replay it and, oh, sorry, and show you some anatomy. Okay. Do you see the V? That's your vocal folds. And if any of the food or liquid gets past the vocal folds, it goes into the lungs. And then over here, the thing in front of it's the epiglottis. And it's the thing that I was saying has to fold over the trachea or the vocal folds. And then it's hard to see, but after that happens, the food goes down into the esophagus. So you're not seeing the esophagus. So here, let's play it again. And you'll see when this person attempts to swallow, a lot of food gets hung up. Okay, so that whiteout is when the epiglottis folded over. And look, you can see the green applesauce, right? And that's what could potentially go down into the lungs. They swallowed again. And these are something called the aryepiglottic folds coming together to help close the glottis, which is good. Now, what's about to happen is, did you see that now the green stuff went away? It's because the person took a sip of liquid. When they took that sip of liquid, it helped transport the food down into the, hopefully into the right place. But you can see, we can see exactly what's happening from this bird's eye view. All right. All right, so stop, and I'm going to do Command Tab maybe.
Or I think actually, if you want, you can stop sharing your screen.
Okay. All right. All right, I've done it.
Lori McGinnis has a question, but I have one. Is that an uncomfortable test? Because it sounds like it would be uncomfortable to have something through your nose while you're eating and stuff. Like it seemed to me like I felt like that would almost
Yeah,
incite
it's
some choking.
uncomfortable.
Okay.
For sure, it's a little uncomfortable. Each person's different. If you have a lot of GERD reflux, then you already have some swelling, and that swelling often goes up to your nose. So, you know, another reason to take your GERD medication. Another reason to take your GERD medication is so that if you have any issues like this, you're not aspirating stomach acid.
Okay. Roger says it tickles.
Oh, good for you, Roger. I got trained in it and it did not tickle for me. But, you know, I had it done during my training 5 times in one day.
Oh.
So it's not a killer, but, you know, didn't tickle.
Lynn said she barely noticed it. So, okay. Because then my next question is,
everybody's different.
Why would you have one test versus the other? Are they looking for different things, or what are they? Why would you maybe do one versus the other?
Yeah, they're looking for different things. They see different things. with the modified barium swallow study, you can see the whole person, and you're looking at the tongue. You're looking at the tongue, you're looking at the folding of the epiglottis, but you're not clear on what's happening at the back of, right below the back of the mouth. And this, these lets you see what's happening with these things called the area epiglottic fold. You're seeing where the food gets caught. You couldn't necessarily see that on the modified barium swallow study unless you have them do a specific view where they're looking at you from the front, and not everybody will do that view. And you also want to reduce the time under radiation when you're having an X-ray. So this one, you can do it. They can also it's just a speech pathologist, and she can more easily have you do some other things too, and try some different strategies.
And Lori, did you want to come off mute and ask your question?
Yeah, I had a question on one of your very early slides that describes some techniques, and that first one was about lying down and raising up your head.
Yeah,
Could you go over that again? Because it seems opposite to the chin tuck strategy.
you're not, yeah, that's an exercise, and what it's doing is training muscles. And so it's training these muscles under your chin, your digastric, your can't think of the other ones. And so what it's doing is improving their coordination and timing. So with the chin tuck, what you're attempting to do is get better coordination and flexibility. You're trying to get the epiglottis to fold over, which is different than that other one where you were actually trying to get your tongue to move better.
So if you were doing the first one, lying down, raising your head, are you swallowing it during that, or are you just practicing lifting up your head? I don't get where the swallow comes
You're
in.
just practicing. You're practicing.
So you're not swallowing is not involved.
Well, you're swallowing, but not swallowing food.
So when are you swallowing? When your head is up or down?
When your head is up.
What she's explaining is one is an actual technique to help you swallow better while you're eating, and one is an exercise to practice to strengthen your swallowing muscles.
Yes.
Okay, thanks.
Okay. Kathy, I see your question, but we do have a couple of questions first. I see you got your hand raised. Someone asked, why does food remain at the back of the throat and not get swallowed?
So it's a person asking, like, if you open your mouth, you could see it? Is that the question? Or is it once it goes past the back of the throat? Because, well, I'll answer both questions. One is your tongue might not be able to catch the food and make a ball, elevate it, and then drop. That's how you have to swallow. You have to make a V with your tongue, or a tongue, we call it a tongue taco. You lateralize the food to the right, you lateralize the food to the left. As you chew, you lateralize, chew, 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 push it to the other direction, chew, 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 put it in the middle, suction, and then you're going to see a ball of food right there in the middle of your tongue. And did you see how the sides of my tongue curled up? That's going to allow the food to be there. If your tongue can't do that, then your food is kind of might be all over the place. And if you don't use good intraoral suction, again, your food is going to be all over the place. It's called piecemeal deglutition, or food being all over the place. And what we want to do is suction it into a ball in the middle of our mouth, raise our tongue up, and swallow. not with an open mouth, but I was just doing it so you could see what's called peristaltic action of the tongue. So, put my tongue up. And you could see the tongue doing this, right? And that wave-like action, we can practice it, and that will help us get the food to not be stuck at the back of the mouth. Now, once it goes down, and we saw in that fees study, we saw the food stuck down there below the epiglottis, it's getting stuck there because some of those muscles just aren't working the way they need to work. And that's a harder thing to deal with. So
We do have a few more questions, but Kathy, did you want to come off mute and ask your question?
I can't hear
Still
you.
on mute. You're still
your
on mute.
lip, but I can't hear you.
You're still on mute. There you go.
Okay, I'm gonna go to speech therapy. I thought I'd, strengthen my voice muscles, my muscles, so I could swallow, because my brother's in the hospital with aspiration pneumonia. He's got Parkinson's disease, and he's got aspiration. So I thought if I go to speech therapy.
Good. Yeah. And so that you're one of the 51% of people who might get helped, with your aspiration, to avoid it by doing the speech therapy, the LSVT loud or the speak up.
Right, but she's going to do the test on me up the nose first.
What's happening?
She's going to do that test that goes up the nose, like you were explaining.
She's going to do a fees. Okay.
Yeah.
For you.
Before I can go to speech therapy.
Yeah. So if she's, so each person, well, she's not probably doing a fees unless, are you having trouble swallowing?
No, I'm not, but I want to make sure I don't, because my brother has aspiration.
What she's doing is called a laryngoscopy. What she's having you do is a laryngoscopy, probably. Before we're allowed to treat people for the speech, we have to make sure they don't have any vocal fold issues. And so you won't be swallowing probably any food, but they'll put the camera up your nose and down your throat, and they'll take a look. Make sure that your vocal folds are coming together. Often what they're going to see is, well, as we get older, our vocal folds bow like that. They don't come together. And so that's why you need speech therapy. It's going to help them come together better. That's one of the many reasons. If they see that, that's expected, totally expected, that might be happening, especially with Parkinson's. But if they see anything else, like, it's rare, but if they see that you have a nodule or a polyp or something else, then speech therapy might not be indicated. It's just to cover ourselves, to make sure that we're not giving speech therapy to somebody who has a pre-existing voice disorder that could be hurt by the therapy.
Should I get a report on that as well?
Say it one more time. I could only hear half of what you said.
Should I get a report from her on that as well?
Yes. You know that everything is reported. In medical, we say if it's not documented, it didn't happen, right? So you absolutely get that. And then you all should know to fill out the protected health information forms that they give you. Those forms are so important. Every time you go into the hospital, every time you go to a doctor, they give you a form and they say, who are we allowed to share this information with? And you should always fill that out and always put whoever it is who's helping take care of you, so if something happens to you, they can help take care of you, because otherwise they literally can't, right? They're not going to be given any information about you. So it's really important. So many people blow it off, but you want to put your speech, and you can specify what you want each person to be able to see and know. But when you go into the hospital, when you go to, I guess it's an ENT, On that form, you write down your treating speech therapist. She's the one who needs it. They'll probably fax her the report. They'll also probably give you a little thumb drive. Hold on, let me see if I can find one. I don't see it, but something like this, something like that, a little thumb drive, and that's going to have your video on it. And then hopefully your therapist can take that thumb drive, plug it into her machine, and review it with you, review the whole report with you. And it's important that they do, because, you know, everybody sees something different on these, and everybody's been trained slightly differently. So getting more than one therapist to take a look at your report is a great idea. So,
Right.
Yeah.
Anyway, I was wondering why, let me ask you, most people, a lot of people with Parkinson's pass away from aspiration pneumonia is the #1 cause. Why don't they recommend speech therapy and all this before it gets to that, to everyone? You know what I'm saying?
Yeah, I mean, I think more and more people, doctors are. I mean, that's sort of my, when I first started working with PMD Alliance, they said, so what's your reason for doing this? And that was really it, is that, if it's to increase the ability for people to know about this. And, you don't have to be told by your doctor to go get speech therapy or feeding therapy. You can do it yourself. At least in New Jersey, there's, well, actually, you do need to get a prescription from your doctor. I'm sorry, under Medicare, you do. But you can be the one asking them for and telling them, like, they have a lot on their plate, right? So it's up to the patient to make those suggestions and, be empowered to get it done. Once you get into the system, hopefully this, it really helps you take care of you. And once you get the right therapist, she's going to help take care of you too.
Yeah.
I have a question about, does sleep apnea have any impact on swallowing?
I don't know the answer to that.
Mm-hmm.
If you're having an apnea, there's two types of apnea. One is neurologic and one is obstructive. And if you're having an obstructive sleep apnea, it's conceivable that you might be getting things stored up, like more saliva stored up or more reflux. And then when you start breathing again, it might get into your lungs. But I think most people, when they start breathing again, gasp. And if you're gasping, that hopefully is going to help expel things a little bit more. But I don't know the answer to that. If you're having a neurologic apnea, which is what might be more likely to occur with Parkinson's, that would be a whole nother question again. So to ask your doctor.
And then again, you had mentioned the breathing apparatus in the beginning of the program. Someone asked, is this something useful?
Yes, and there we go. All right, so here's the breather. This is the one, there's a bunch on the market, but a company approached my company and gave us these. Didn't give it, but they gave us one or two, and then we did buy a bunch. And then what you do with these is, I can show you. Open up the box. There you go. So this is an expiratory muscle trainer and inspiratory. Inhale means inspiratory, exhale is expiratory. And so when you inhale, you can choose what level, 1, 2, 3, 4, 5, 6. And you're training your lungs to inhale against more resistance. And you just turn it. Or you have somebody else turn it. There you go. Turn it. Mm-hmm. And you're supposed to breathe in, you're supposed to do 20 inhalations, and then you do 20 or at the same time 20 exhalations, and you do that against resistance as well. And yeah, this is known not only to help your breathing function, but it's helping to, believe it or not, by increasing the strength of your diaphragm, which is a muscle that helps you breathe. That helps to make the small little sphincter, the lower esophageal sphincter, tighter. And when that's tighter, there's less reflux happening. And that's a good thing. And then on top of it, it also will help you cough, because you're going to have more strength to cough. And that will help you if you needed to expel food or liquid from around your trachea.
And then you had mentioned in your talk that they don't think the water in the saliva is as linked to the aspiration, linked to pneumonia as they thought. Could you talk a little bit more about that?
That what?
You had said in your talk, because someone asked about if saliva, if you're storing the saliva, does that make an impact on the exercises? And you had said that they actually don't think anymore that the water and the saliva is as impactful as initially thought.
Yes, it's because that was when we got to the Fraser free water protocol. Mm-hmm. That is the research done around that mm-hmm. things, items such as water or saliva are neutral, tend to be neutral. And when they enter the lungs, they tend not to cause as many complications. But that is, of course, still being researched, and some people think it's fine and some people think that's a load of baloney. But yeah, but if you really need that water, I bet you're hoping it's not a load of baloney.
Yeah.
Did that answer the question? I hope it did.
Yeah, I had not heard that. Like, I always thought, the water, anything in the lungs could then potentially become pneumonia. And so when you said it, I just kind of made a note to myself to ask the question. So, well, yes, Gary, did you have a question? Do you want to come off mute? There you go.
Can you hear me?
Yeah, what's your question?
I have PD, and a concern I have is that I have very active sinuses at times, sinus infections, and there's a lot of snot developed there, and often, normally I sleep on my side or my stomach, but at times I'll turn over on my back, and in the middle of the night, I feel like I'm being waterboarded with snot is the best way to put it. Is there anything I could or should?
Yeah, so I love to send people to this website called, wait for it, acidwatcher.com. Now, your doctor can tell you why, who knows what it is. Are you having allergies? Are you always sick? But the guy who writes acidwatcher.com has come up with another term for why we have a lot of discharge, discharge going down our nose. And he thinks it's because of a reaction your body is having to highly acidic foods or very low acidic foods. And what he thinks is happening is we start to have that happen, that drainage happen, and your body changes the acidity of the nasal drip to help either neutralize the acid or make it more acidic in your system. So I would look at your diet and go to acidwatcher.com. The guy's really has some interesting ideas. But I noticed if I eat something I shouldn't eat, like ice cream before bed, guess who's going to have that exact same thing? Mm-hmm. Me. And so, I just wonder about that. Now in terms, so are you saying that when it happens, you can't breathe right?
At times it feels like it's totally clogged, like I can't breathe at all. There's
Are
no,
you coughing?
yes, I try, coughing. Generally after getting up out of bed, still out of breath and not being able to breathe, I'll get things moving and it'll start, releasing itself. When I think it's probably, I'm sitting up from bed, I'm no longer accumulating the snot down the back of my throat.
Right, exactly.
It's not-
You might want to get a swallow study done, just to see what's going on. It may be, well, it's hard to say, but it may be that there's some swallow strategy that would help you, or something that's not as functional, like needs to be strengthened in order to help you get there. In order to help you to swallow correctly. But yeah, I think part of the biggest issue is that it just continues to drain, right? If
Right.
that wasn't happening, because during the day, are you fine with the amount of saliva in your mouth, and you don't have these issues?
Yes, that's no problem during the day.
Yeah. Yeah, so those are some ideas I could have, but go talk to your doctor, like with all of this, just get to your doctor, and if he doesn't give you a good enough answer, find someone else. But I would guess that having an actual swallow study done might assist you in knowing more about your condition.
So my question only
Hey,
is,
I'm sorry. I do have to cut you off because we are out of time, but somebody did ask, what again is the name of the breathing tool that you showed?
The breather.
The breather.
The breather. And it's a respiratory muscle training device.
Perfect. Thank you so much. Thank you so much for giving us your time again, Michelle, because you've really been doing a lot for us lately. As always, at PMD Alliance, we have our wave of gratitude. Thank you so much for being here, for giving us your time, and I hope everybody has a safe holiday tomorrow. Bye, everyone.
I thank you.